and then re-entered psychiatric unit. Okay, also electroconvulsive therapy lagi, but then afterwards she was discharged and then underwent different pharmacological strategies. So you see all of this, okay, fluoxetine 40 milligram, including all these dose elevation and also dose optimization cover and a change of alternative agent as well. You see banyak kan kat sini. So finally she achieved remission of psychotic symptom and partial improvement while she was on treatment with lamotrigine and aripiprazole, but she did not achieve a complete recovery. Okay, so nak kata susahnya nak dapatkan optimization of the therapy tu. And then dia dapat juga, the key a key factor in the clinical management of this case is difficulty in maintaining the prescribed treatment and to optimize dosage because of side effects. So this patient developed side effect seperti weight gain, drowsiness, quetiapine, clomipramine, GI, side effect, okay, hematomas, distal tremor, all of the side effect yang menyebabkan patient tu tak boleh tolerate. Okay, so in February 2015, patient underwent this neuropharmacogen testing. This is pharmacogenetic testing. So patient punya result intermittent metabolism for CYP2D6. Indicating possible reason for tolerability problems and side effects to many antidepressants and antipsychotics use. Okay, so if we refer back to the lecture tadi, so this patient have intermediate. Okay, intermediate maksudnya the patient ada combination of either of this. So dia mungkin ada one allele of loss of function tadi, inactive enzyme tadi, a combination with allele lain yang normal lah. Okay, mungkin for star 4, star 10 ke contohnya, because star 10 is normal, okay. Ataupun star 1 which is wild type and star 4, okay. So a combination with normal dengan loss of function, maksudnya inactive. So this patient having that genotype ataupun phenotype. So that's why it explains the tolerability problem. Mungkin sebab tu dia punya metabolism of that drugs that is metabolized by CYP2D6 mungkin slower sedikit. So that's why this patient ada this kind of side effect lebih daripada orang yang mungkin normal punya metabolizer kan. Okay, so in addition, escitalopram is mainly metabolized by CYP2C19, which is a minor substrate for CYP2D6, and its main active metabolite is only partially metabolized by CYP2D6. Therefore, it would be less likely that the patient presents tolerability issue. So this patient mungkin tolerate dengan escitalopram because escitalopram hanyalah minor sahaja being metabolized by CYP2D6. Mainly it's CYP2C19. Okay, so kita ada penjelasan kenapa this patient is having this problem. Yang tu side effect yang ni dia tak tolerate side effect yang ni tapi tolerate pada yang ni. Okay, because we know behind it, okay, this patient punya genetik yang menyebabkan dia jadi macam tu in terms of their response. Okay, so from October 2014, patient treated with escitalopram, the lamotrigine was maintained. Okay, so maksudnya in the end, the treatment tu is tailored kepada patient punya CYP2D6 punya result, and even though there is no change of dose, but it explains why this patient tak tolerate kepada side effect tu. So ia boleh membantu kita membuat decision seterusnya atau kita tahu kenapa. Okay, so that's the main thing that I want to highlight in that case. Okay. Okay, so we go to antidepressant pharmacotherapy. Itu pun kita dah cover tadi sikit. So we look at the overview of major depressive disorder treatment. If you look here, the treatment is also not straightforward. Kita ada psychosocial intervention, psychotherapy, and plus pharmacotherapy, which is our antidepressant tadi. And biasanya the progression to the patient gain the response of the treatment tu is also not immediate. For example, here around 12 weeks baru kita boleh nampak patient punya progression. Okay, and you boleh bacalah kat sini the selection, SSRIs, SNRI, serotonin noradrenaline reuptake inhibitor, dan macam-macam lain lah yang lain. And these are the examples of the antidepressants, including the dosage and also common side effect dia according to the class of the antidepressant. But the common that we can see SSRIs lah, biasanya escitalopram, fluoxetine, fluvoxamine, sertraline, okay, ataupun SNRI, duloxetine, venlafaxine. Biasanya kita akan nampak patient started with SSRIs punya dulu, and then if the patient is not tak respon ke apa, and then kita we can see that patient mungkin started with SNRI ke. Okay, tricyclic antidepressant here is an older drug. Mungkin some patient tolerate, some patient do not because of that side effect. Amitriptyline, imipramine. Okay. And what is the enzyme that are important? We have additional of CYP2C19 here. So CYP2D6 kita tengok tadi kan. So if you look at amitriptyline, CYP2C19 is the major metabolic enzyme and it will be metabolized into nortriptyline. Okay, so yang ni sama macam tadi je, CYP2D6. Okay, kita dah tengok tadi which allele is important. So now we come to CYP2C19. Okay, CYP2C19 enzyme. Yang ni simple juga, is actually if you want to focus on the actionable phenotype, you have to look at also ultra rapid and poor metabolizer. Okay, ultra rapid metabolizer, an individual carrying 2 increase of function allele. So increase of function allele for CYP2C19 is star 17. Okay, star 17 maksudnya if the patient carrying 2 allele, they're homozygous for increase of function allele, which is star 17. So this patient is phenotype dia ialah ultra rapid metabolizer. For poor metabolizer, if the patient carrying also homozygous of the non-functioning allele. So non-functioning allele for CYP2C19 are star 2 and star 3. Dua saja. Okay, kalau CYP2D6 tadi, poor punya apa yang inactive, loss of function allele is star 4, star 5 and star 6. Okay, 4, 5, 6. Kalau CYP2D19, star 2, star 3. Okay, a combination of these two non-functioning allele patient tu ialah phenotype dia poor metabolizer. Okay, dan kat tengah ni is a combination of wild type dengan ultra rapid ataupun increased function, patient tu jadi rapid sahaja. Star 1 is the type, the normal punya. Okay, so normal metabolizer. And ada juga combination likely intermediate ni, ada combination of star 1, star 9, itu ialah the star allele that cause an increase in function ataupun a decrease in function. Tapi a combination allele dengan wild type. Dia akan jadi is either likely intermediate ataupun intermediate. Kita tengok dia punya combination dia lah. Contohnya intermediate metabolizer ni dia menghala ke poor lah. Maksudnya dia reduce in function tapi tak adalah sampai jadi poor metabolizer because dia ada juga wild type tadi. So combination of wild type dengan only one sahaja allele that cause a loss of function. Okay. So these two lah yang ultra rapid star 17, star 17 ataupun poor metabolizer, a combination of star 2 and star 3. So that would be poor metabolizer. So CYP2C19 is main metabolizing enzyme for TCA, amitriptyline and SSRIs, escitalopram, citalopram and sertraline. Okay. So I have simplified this in this table. Hopefully it's still valid lah. I tengok yang reference from 2017. Also from CPIC guideline juga. So it has the recommendation apa kita nak buat. Okay, if your patient is having this phenotype. So it's according to the phenotype dah sekarang for the recommendation. Contohnya for amitriptyline, For amitriptyline, if the patient have CYP2D6 ultra rapid, it's advisable to have alternative drug. Okay, if TCA is warranted, consider higher target dose and use TDM to guide the dose. Okay, sebabnya amitriptyline tadi, if we can see, amitriptyline, CYP2D6 tadi, if dia punya metabolic enzyme also CYP2C19 and also CYP2D6. So if the patient is ultra rapid metabolizer for CYP2D6, it's recommended to have alternative drug for this patient. And if you can see here, poor metabolizer, also select alternative drug as well. But if TCA is warranted, consider 50% reduction in the starting dose. Okay, sebabnya the poor metabolizer, it will be metabolized less. So that's why kita takut accumulation. So consider 50% reduction in the starting dose. Okay. And tertiary amines like amitriptyline, clomipramine, imipramine, doxepin, CYP2C19. Sebab amitriptyline tadi kan ada juga CYP2C19 as the metabolic enzyme kan. But then it is optional in terms of the level of recommendation is optional. Sama ada kita nak follow ke tak lah. But for CYP2D6 is strong for ultra rapid and poor metabolizer. So this is for tricyclic antidepressant. So this one is for SSRI, paroxetine, fluvoxamine, citalopram, escitalopram, or sertraline. So paroxetine and fluvoxamine, CYP2D6, escitalopram, citalopram, sertraline, and CYP2C19. But if you see the level of recommendation here, strong is only for paroxetine, ultra rapid metabolizer. So strongly indicated to change the treatment to an alternative agent. Mungkin a different SSRIs ataupun SNRI for example. Okay. Okay, we go quickly for this ABCB1. This is if you can remember gambar tadi for antipsychotic tadi, risperidone is transported by PGP, right? PGP, it's encoded by this ABCB1 gene. So the active ke tak active ke P-glycoprotein ni, it depends on the genetic variation jugalah of this gene. So the most popular one is RS10456423435CT. CC genotype associated with a lower efficacy of paroxetine due to the increased PGP efflux of paroxetine. Therefore, there is less amount of paroxetine enters the blood circulation to exert pharmacological effect. So dia punya kesannya tu is related to the distribution lah. Because PGP ni is a transporter protein. So it transport paroxetine from the cell into the circulation. Tapi if there is a defect, ataupun if there is lower efficacy of PGP because of this genetic variation, maksudnya less of the paroxetine go to the circulation and take, provide the effect, the gut receptor. Okay, so that's ABCB1. And also this one SLC6A4, which is the serotonin transporter protein punya gene. Okay, serotonin transporter. So main target of action of many antidepressant. Nanti you refer balik kepada lecture of mechanism of action of SSRIs. Itu dalam punya pharmacology punya CNS hari tu kan. So you tengok balik apa dia punya mechanism. It affects the, bukan it affects, it binds to the serotonin transporter protein. And if the protein, transporter protein itself is increased in activity ataupun expression dia increase, then the effect or the response for this drug would also be increased. Contohnya, this 5-HTT-LPR, also known as the long allele, because it has repeat element. So if you remember dekat genetic variation punya lecture, there is also a type of genetic variation in which there is a repetition of the section in the allele or in the gene, VNTR ataupun SNTR kan. So there is a repetition. So makin banyak di repeat, makin panjanglah allele tu. So that's why it's called long allele. Okay, so patients with long allele, dia lebih respons sebab dia ada lebih banyak that protein tu. Okay, and also this additional ni RS25331 and also STIN2 VNTR polymorphism show better response. Tapi the important one, more important would be the 5-HTT-LPR ni lah. Okay, if you can remember the long allele, 16 repeat allele ni maksudnya there is a longer punya allele ni, maksudnya dia punya expression of that protein tu lebih banyak. So that's why the effect would be better. So patient yang ada this long allele, dia lebih respond kepada SSRIs. Okay, ending this lecture would be to recap back patient yang awal-awal tadi, Ali tadi, 43-year-old Ali tadi. Patient was given apa tadi? Which drug tadi, if you can remember? Amitriptyline and citalopram. Okay, so just prior to hospitalization, you ordered the pharmacogenetic test. The results show that Ali has CYP2D6 *1 *1 times 2 and CYP2C19 *17 *17. So now, can you recall back CYP2D6 *1 *1 times 2 each represents which phenotype? Where else for CYP2C19 *17 *17, what is the phenotype? Kalau you remember tadi, can you put in the chat? So what phenotype does this patient have? For CYP2D6 apa? CYP2C19 apa? So there's two type of phenotypes sekarang depending for each gene, dia ada different phenotype masing-masing lah for each gene. CYP2D6 apa? CYP2C19 apa? Okay, Maisie, ultra-rapid. Untuk mana? Yang mana satu? Dua-dua ke? Arif Azmi, ultra-rapid metabolizer. Okay. Ziying, both ultra-rapid metabolizer. Yeah. Okay, sebab tadi if you can remember *1/*1 times or berapa-berapa pun, it means that there is a duplication, multiplication. So ultra-rapid for CYP2D6. CYP2C19 *17 *17 ultra-rapid because yang poor metabolizer would be *2 and *3. Itu yang poor metabolizer for CYP2C19. So this patient both ultra-rapid metabolizer. Okay, genotype results suggest that he had low exposure to amitriptyline and citalopram due to high CYP2D6 and CYP2C19 activity, leading to rapid metabolism of these antidepressants. So does venlafaxine was chosen as an alternative antidepressant because exposure is not as dependent on CYP2D6 and CYP2C19. But further monitoring is required to ensure the treatment optimization. Okay, so if you are given this kind of case study in the exam, so you know that you have to interpret the genotype first. Okay, so you interpret, if I give 2 or 3 of this genotype result, you should be able to interpret. Okay, yang CYP2D6 ni patient ni dapat apa? Ultra-rapid ke, poor ke, intermediate ke, extensive ke, okay? CYP2C19, I bagi this one, patient ni apa punya phenotype. So you have to interpret that one first, and then you need to recommend. Because you should be able to know lah kalau dia ultra-rapid menyebabkan apa. Kalau dia poor metabolizer menyebabkan apa. Okay, then what would be the recommendation? But be careful for drugs that are pro-drugs. Kalau pro-drugs, maksudnya it will be the other way around. If there is an ultra-rapid metabolizer for this enzyme, but then actually the enzyme is needed for active conversion. Maksudnya daripada pro-drug kepada active. So ultra-rapid metabolizer for that drug is going to cause an increase in the level of the drug, bukannya decrease. Okay, so you have to know your drug and then you have to think how it's going to affect the patient punya treatment nanti. Okay. All right, and that's all for lecture 1. Terlebih sikit 4 minit. So can yes, if you have any question, you can put in the chat. So can we have like a 5 minutes break before we continue with the next topic? Boleh? Okay, so I'll see you 12:09.